started off with our first event on how we can better understand our stakeholders and work out how we utilise our stakeholder analysis, our matrix tools to help understand what power and impact have and the organisations in relation to your improvement work. Our last event focused on understanding the problem. So where you take the time to work out the question of what you're trying to solve. Is that the right problem that you're trying to solve? And today we're going to focus on the project's aim, what you're hoping to achieve now that the problem has been identified. And then we'll move through the processes, learning as we go, sharing some great presentations where we can all take some learning from quality improvement work that they've done. So before we move on to our focus of today, I just wanted to talk to you about some concepts that you can hopefully think about later in your breakout sessions. So when you're embarking on or involved in a quality improvement project, it's really good to think about the collective intelligence of the team that's around you. So the collective intelligence is something that emerges from the collaboration of the collective efforts and competitions of many individuals. So at its simplest, your collective intelligence can be understood as the enhanced capacity that is created when people work together. So often with the help of technology to mobilise a wider range of information, ideas and insights. And it also takes into consideration 4 elements. So openness, peering, sharing and acting wider. So the openness, simply put, is this condition that implies that all participants approach their work or a project without thinking that this idea is mine. And peering is when that collaboration will happen horizontally, so without a hierarchical approach to it. It allows everybody to be equal contributors in sharing their ideas. And that sharing clarifies the need for individuals to freely exchange ideas backwards and forwards. And this condition is essential for collective intelligence, because when team members are held back, they deprive the group of those ideas and critiques that could actually steer them forward in their innovation. And then siloing can prevent these teams from advancing. So acting wider encourages groups to reach out across their entire network of collaborators and overcoming those barriers. So then the next part of this is cognitive diversity. So when teams face complex problems, they need to harness their collective intelligence to find solutions. However, even a skilled, intelligent group of people will fail if the team members share the similar backgrounds or perspectives. So working with people who are similar might feel great, but it doesn't always get the outcome that you want or you need. So you might think of this collection of circles of people that you can see on screen. They've all trained at the same university or had the same placements or work base in the same department, or they might have even come from the same country or part of the country. So when you start to introduce people that are outside of what might feel more comfortable, you have less overlap in that knowledge from their backgrounds, perspectives, and skills. So each team member's different background and perspective contributes to the collective intelligence. So in effect, teams can produce more unique, helpful ideas than just a team of clones. And sometimes these conversations in the team might feel a little bit challenging, but lead to better solutions. So creating that universe of useful ideas. So maybe think about the team that's around you and consider yourself whether you would have an intelligent team or not, and maybe what you might do to expand that. So when we do have the opportunity for a little breakout later, maybe think about this and use this opportunity to widen your circles, your networks, and those that you can gain that additional insight and maybe soundboard with others with sticking points of your projects or the ideas that you have. So now on to the more exciting bits that you've joined for. So just to talk you through our agenda for this afternoon, we've got our first presenter, which is Alma from the Health Innovation, who will talk to you about what you need to know about your aim setting. We'll follow with this up with a breakout room to initiate some peer-to-peer QI conversations. Next, we've got Jennifer, who's our obstetric consultant at South Warwickshire University NHS Hospitals, who will be sharing the work that they've done on improving the PPH rates. And lastly, we've got Eleanor, who's a consultant midwife for quality improvement and population health at CTM University Health Board in Wales, and we'll be talking about the OBS bleed strategy work. So I do hope that you really enjoy the event and get something valuable out of it. And now I've got the pleasure of passing you over to Alma, who will take the floor.
Sorry, Kirsty. Alma was just saying she was having a little trouble finding the link. I've just forwarded it on to her, so hopefully she should be with us.
Thank you. Hi, Alma.
Hi, Kirsty.
Yeah, we're ready for you when you're ready.
Lovely. Sorry about the technical glitch. So I have the joy of sharing some setting your aims learning, shall we say. Right, I'm just going to try and get that set up from the beginning. So hi, sorry I missed your introduction, Kirsty. Delighted to be here this afternoon. So I'm Alma Gallagher, I'm Deputy Head of Improvement Team at Health Innovation East Midlands, and I've been the Maternity SIP lead for the last year as well. So that's how our paths crossed as we were, I think, delivering Each Baby Counts toolkits. So well done on this event and pulling this together. It's great to have so many people involved and thinking about QI in their work, because ultimately quality improvement is everybody's business. So just looking at what I was hoping to talk through today is just to try and demystify aim statements. I think we can get sometimes burdened down by some technical language, and so it can become a bit of a barrier. So hopefully we'll work through some of the methodologies, some of the keys to success, and hopefully by the end of today's session you'll have some more information and tools to work and make a start. And hopefully at the end or through the session there'll be opportunities for any questions or shared problem solving. So before we started, I was hoping people could select where they are on their aim setting skills. You might recognize this. This is the Bennard's novice to expert model. I wonder if you could, where are you in your skills around aim setting? And if you could pop into the chat whether you think you're a novice or an expert, or somewhere in between. And I think we often perhaps move between these stages, but be really keen to get an idea of where people feel they are in their journey. So we'll just take a moment to, if you pop in, whether you're a 1 today or a 5, that's great. So thank you. I'm going to, so just a bit of background. I think starting at the beginning is, it's, you know, this whole forum and the fact that you're on this call shows that you're one of the willing change agents. And so that's fantastic. And I guess I just wanted to recap before we start thinking about aim statements about what is quality improvement in assessments. And I guess there's so many different methodologies and approaches, but equally the Health Foundation have identified some key principles, which are starting out with identifying your quality issue. What's that thorny problem that you've struggled with, or that your patients or staff group are struggling with, or your organization has as a priority? And then you need to understand that problem from a range of perspectives. It's not just that, Alma has, this is a problem for me, without taking into account whether that might resonate with other people, or perhaps you see it through too narrow a lens. And it's really important that we have that collective understanding of the problem. And obviously then it's about developing a theory of change as to identifying that problem, what it is that might need to improve. Either we want to increase the availability of something or decrease the way we do something, so that we've got an outcome, and that's important as well. So whatever methodologies you use, these are common principles. then it's also really important about to identify and test then potential solutions. So we really need to be using data and measurement to understand whether the change that you're having has had an impact, whether that's a positive impact or perhaps an unwanted impact. And so you have to have a methodology or approach that can pick up on those changes and allow you then to refine that change idea to see to whether you want to adopt that model or what that changes, or you need to adapt it or actually just abandon it. So that is one of the core principles as well. And then obviously with the success of any good quality improvement project is that it's sustained and it becomes part of business as usual, so part of your standard practice. And so that's really important as well when you're thinking about any of your projects or any plan for improvement that you're making, is actually how will we make this business as usual, our standard practice. So that's just the background of it. And I think also just wanted to share that's really important, like any good PDSA cycle, it's really important to reflect on what's gone well and what's gone before you. So the Health Foundation funded an evaluation of, I think, 15 quality improvement programs that took place over a period of time. And some of the common challenges that were identified through these different programs was that actually it's really difficult sometimes to convince peers that there is a problem in the first place. It's also perhaps difficult to convince peers that the solution you're choosing, that change idea, is that actually that it is the right one. And sometimes it's really difficult to get data collection and monitoring systems right. I think you'll all echo that that is certainly a challenge. That, you know, we might be collecting data on oranges, but actually what we've really realized is it's actually the pears and the apples that we needed more information on. And the other thing I think I have certainly fallen foul of this a number of times is that we've got excessive ambition, or the projectness is so precious that actually that becomes bigger than the impact or the plan, and that actually it's really important that we treat the intervention as a discrete, time-limited project rather than thinking that's something that's going to continue going on and on. And I think especially, you know, with staff pressures where they are, with workloads and everything else that you're facing, it's really important that we focus on that time-limited, discrete piece of work, that it's not something that just rolls on forever without meaningful change or impact. And also it's really important that we consider that the side effects of change, what that might mean. It could be that staff feel that they're having to do something new that's being done onto them. It could be that actually one of the changes has had an unwanted impact. So you need to be mindful of actually how you monitor and check what those side effects potentially might be, and that you're looking out for those. So if you get all of that right, and we can take the time to get that right, to get the theory of your change, your measurement and your stakeholder engagement right, actually really, really support you in delivering the enthusiasm, the momentum and the results that characterize improvement at its best. So try not to be like myself, which is when I go to decorate the house, I'm desperate to get the paint on the walls, and be more like my husband, who thinks about the improvements that need to be done, the preparation and what have you beforehand. Much more successful. So you'll all be very familiar, I'm sure, with the model for improvement, and that's certainly the model that we base our work around in Maternity SIP. So you'll be very familiar with this model, I'm sure, but just to recap, there are two parts to it. So there's the three fundamental questions. What is it that we're trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? And then it's followed by the rapid cycle improvement cycles, PDSA, so your plan, do, study, act cycles. And they test and adapt the changes that you've put into place to ensure that over time you achieve the desired improvement. So there we have. So that's some of the background as to why are we doing aim statements? So an aim statement specifically lends itself to what it is we're trying to accomplish. It's really important that we set out a clear aim statement, because it sets out what you want to achieve from your change. By creating an aim statement, creating an aim statement might seem like an obvious start point in the process of change, but in the rush to find a solution or a quick fix to a problem, it's often left unanswered. And I think we all reflect on some of the quality improvement projects or interventions that we've done, and find that actually being gung-ho is fantastic, but actually it's really important that you plan and articulate what it is you're aiming to achieve, because otherwise you find yourself 3 months down the road and not really knowing if you've achieved your desired outcome. And it's really important to take the step before you start your project. So that's what aim statements aim to support you with. Why create an aim statement? Because it will help you to clearly articulate what it is you want to achieve. It will help you to determine what you will measure, so you'll know whether you've achieved your aim or not. And it'll help you to make sure your project is important to you, so it's relevant to you, your team, your organisation, and also whether it's realistic in that it's within your reach. It will also help you to engage other people who share your interest in achieving this goal. So that's why we're doing aim statements. And how do we do them? Well, all aim statements should meet the SMART criteria. That means they need to be specific about what it is you want to improve. That means you need to ask the who, what, by what do you want to increase something or decrease something. It needs to be measurable, so include a measurement that will evidence your improvement. So what is your baseline now? What's telling you that this is a problem that needs to be addressed? It needs to be achievable. So setting a realistic target that and being really pragmatic. There's so many must-dos on your plates, but actually without an achievable, realistic target, it's just pointless. So I think, take smaller steps, be less ambitious if it means you will achieve your target, and make sure then also that it's relevant. I think that's a really important lever that we often don't link in with. So link it into your trust strategic aims, if that's about staff satisfaction or patient experience, or if there's been a number of complaints around a particular issue that's a real driver. Or you can tell from your staff survey that there's a particular issue within your service or team that you want to try and address and improve. So linking it to those strategic aims is a really strong lever to get the buy-in from your colleagues, from your team, from your senior managers as well. And obviously making sure it's time bound, so including a time frame for your project. So that is, and what I've shared here is a SMART aim template, because if we use this template, so being specific, we'll end up actually writing your aim statement. So for example, here we've got your specific improvement might be to reduce the number of falls within the care home by 50% from the current baseline. So we've got a measurable here, which is of an average of 10 per month, and it's achievable. So feeling confident that this could be reduced down to 5 per month, 5 incidents or falls incidents in months. It's relevant. The relevance doesn't need to be stated in your aim statement, but it's one of those levers that I mentioned about whether it's your team or organizational aim or ambition. So think about engaging and improving staff or patient experiences or outcomes. That could be a really strong lever. Include then about the time frame, being really realistic. Is this something that is going to be achieved within 3 months, 6 months, or 9 months, or in fact actually 2 years may be your aim, but it's about. So if you use this template, which will be shared in the slide deck, it will help you to build your aim statement. Okay, so, but it's okay to get it wrong, because if we go back to Benner's novice to expert, if you're doing, it's okay to try off, and I think your first attempt might might be not as specific as you might have wanted it to be, but you can continue to hone it and change it, and don't be afraid of getting it wrong. That's what I would say, is just continue to hone it, work with those around you to make sure that it makes sense. But over time, you will develop the skills, you will be able to kind of develop that understanding of actually, the more information I've got in this aim statement, the more successful my project's going to be, or the easier it's going to be for me to measure that this has been an improvement. And so don't be afraid of failure, is what I would say there. I've included some examples here as to what an effective aim statement might read as. So again, it's going back to those SMART aims. An example here is to improve the patient experience during labour for Black birthing persons, as measured by an increase in patients reporting that they were listened to from the current rate of 25% to 75% by September 2024. So that's setting out your high aim of the overall aim or goal of your project. Similarly here, you want to increase bowel cancer screening rates amongst patients aged 50 plus who identify as Chinese. So that's really explicit. That's a clear population. And you want to improve that from 50% to 70% by May 2025. You want to reduce harm. So you're setting out, you want to reduce rather than increase or improve harm from the use of anticoagulants from the current rate of 1.8 per thousand admissions to less than 1.4 per thousand admissions by January 2025. And they've also included a stretch target of wanting to reduce that even further, again, by less than 1% by January 2026. So that's where your project can be, time-bound, specific, but also realistic, recognizing that they're not going to make that full reduction in that first period of time. That will be something in the second year. And the final one, that's an example here, is to reduce waiting time to be seen for clinical assessment for all patients who present to a maternity assessment unit to less than 15 minutes by July 2024. So again, that's specifically speaking about a particular service, and it is those presenting for a clinical assessment and wanting to reduce the waiting time down to 15 minutes. So that so they are examples that might help you in your aim statement. So I've got a task, and I was just wondering, could you, I'm being inspired by Marie Kondo, fold a t-shirt better. And I wonder what you can do with that task. If there's any problems, perhaps, with just fold your t-shirts better.
How much is better?
Ah, yeah, there's a couple of problems. Yeah, so how much is better? Exactly. Anything else? What is better? Better for you, better for me? So if we think about it, actually, some more information would be needed in that. So what does better mean exactly, Kirsty? And that's different for everybody. So what's better for you might be worse for someone else. Is it measurable? What are you measuring as better? So is it better so that I can fit 20 t-shirts into my drawer rather than 15? Is it better because I can see all my t-shirts because they're nicely folded in Marie Kondo's technique? Is it better because it actually took less time? So without stating that, again, it's, it is, who'll know if it's a better outcome or not. Is it achievable? So you don't know, because we haven't set out the specifics for the first two. So my task was absolutely set to fail. Is it relevant? Is it better? Is it what you wanted to achieve? It may be, was it about quality or was it about time? Was it about saving my sanity at the weekends, folding all the laundry up, or was it to save my husband time when he goes to choose clothes for the kids from the drawers? So really, what was that relevance? and time bound. There was no indication of what time. Was it a one-off, or is it something to be sustained and throughout the whole of, May as we head into it? So that's why an example of really it's important that your aim statement covers some of this out. And I suppose I've just included here some key aim statements, that steps to success. So to recap is about using the aim statement template. So we'll share that in the slide deck. It's about starting with a simple statement of your aim for your first attempt. And as you learn more, you can improve on this with second and third attempts. And don't be afraid of finding yourself some way down your project and realizing your aim statement needed to change. And actually you're set, that don't be afraid of failure, to reset, agree that change with others, and then just move forward again. Make sure also it's within your reach. If it's too large, or if it's not within your sphere of influence, then try and scale it back to being realistic. That's so really, really important. And again, avoiding that vague aim statement that could mean different things to different people. So it's really important that you're clear. What does complete mean? Does that mean that the whole form has to be filled in, or just the box that you're interested in if your change idea is a pro forma? And again, can't emphasize enough that a realistic aim is smart, but it might take that time, and it could be your second or third attempt that really hones that aim statement. But as I said, don't be afraid, and don't be put off by that. And I guess also so incredibly important with any of our project work that actually you talk to your colleagues, to those patients that are affected and their carers, and ask them, what do they think about your aim, and the overall ambition of your project, and articulating that problem. So that is a whistle-stop tour through aim statements. And I'm going to be really unfair now and ask you to kind of see if this presentation has helped change any of your confidence around aim setting in a real whistle-stop tour. And if you wouldn't mind popping into the chat if you have any change in your confidence levels, whether you think maybe you might be an advanced beginner, or actually you're reassured and you kind of think, actually, do you know what? I'm not a novice. I'm actually quite competent, because what Alma's just recapped has helped reinforce what I already understood. So, and of course, maybe in that 15-20 minutes, you managed to become an expert, in which case I applaud you. So that is the end of my presentation. And I guess whether there's an opportunity, I'm not sure where we are in time, Kirsty, but happy to answer any questions or support any shared problem solving. I'll stop sharing now.
Thank you, Alma. That was really insightful. And I think the thing that I always have to remind myself is that it's okay to go and change your aim statement. And I think you always feel quite bound and stuck by something that you go to initially. So that's always a very useful reminder for me. Yes. But yeah, if anybody does want to clarify anything, there is a little bit of time. If you wanted to ask, feel free. If you feel confident, you can come up on the mic, or feel free to also just pop it in the chat, and we can answer it on the chat for you. And yes, I will send out links to everybody that has attended for a copy of the recording, and also the slides that have come with today. And thank you, Catherine, feeling more confident and new thought. Right, everybody should be zipping their way back in, and hopefully you managed to have time to wrap up your conversations and finish saying what you wanted to say. And I hope that was beneficial for people to try and just understand different perspectives of their projects and take learning from those that might have done well and those that might not have succeeded in their projects as well. Dipping in and out of your rooms, I could hear lots of variety, lots of different projects, people sort of sharing from their different perspectives, some people sharing their project work, which is really nice as well, to say, yeah, contact me, share this over, send it over, I'll help. And I think that comes back from we're here to learn from each other. We shouldn't reinvent something all the time. Let's think what other people are doing and where can we take learning from that and apply it to our projects that's relevant for us. Did anybody want to share what they got out of their breakout rooms? I think there were 7 rooms. So maybe room 1, what did you sort of talk about in your room? Or anybody can self-volunteer to share.
Hi everyone, I'll go. Angie Tashani. I can't remember which room we were. We didn't get down to creating a name for our room, but we had some amazing women in the room, and I think our take-home message was really about supporting each other on this QI journey and learning from each other. So there was a colleague in the room who was just embarking on the induction of labor sort of QI stuff, and we at Leicester have done some work around that, and I thought it would be great for us to connect. Because I think it's really important. I'm sure, and we spoke about a bit about culture of organizations and how different organizations will have different cultures. But at the same time, it's a shame that there's amazing pockets of QI work that happen across the country. But unfortunately, we're spending too much time reinventing this wheel. And I wish there was a mechanism by which we could actually share that learning of what works and what doesn't work, so that within reason, I always say, if you want to plagiarize, just give credit to the place where you plagiarized from, because you're not going to make the wheel any more rounder. And then we were speaking about the piece of work that I've done around inequalities, and it's just again another piece of work that's out there. And if people wanted to connect into something to help with South Asian women and reducing inequalities, again, it's that network. So I think we spend a lot of time talking about networks. And we spent a very, very little time talking about how getting the aim, which Alma spoke about in great depth, is right, even if it takes you a while. We're on this perinatal mental health QI project, and it's taken us 3 months, and we still haven't decided what our aim is, and it's an 18-month project, so you can get an idea of why it's important, but why it's so difficult as well to try and agree on what an aim should be. I think that was a summary of our room. If anyone else is in the room, and if I've missed out anything, guys. No, they're nodding, at least the ones I can see.
That's great. So that sounded really beneficial. And obviously people can use the chat to just say, I'm working on induction of labour. Anybody already done a project? Can you please send me an email? Like, there's no harm in just shouting and making those connections as well, just to have that 20 minutes where you can have a cup of tea over Teams and just talk about where your sticking points might be and where their project is or has been, and you can learn from that as well. So we're going to hand over now to Jen, who's going to be presenting the work that she's done at South Warwickshire on improving PPH rates.
Thanks, Kirsty. I'll just bear with a moment while I do a little bit of screen sharing. Hopefully that should all have appeared. So Kirsty's very kindly invited me to talk to you today. I'm one of the consultant obstetricians at Warwick with Kirsty, and this is really just to share a QI project that I was leading on at our trust, and hopefully this will be something useful for yourselves, because I know this is something we've all been struggling with. My screen will work. Here we go. So really this QI project came into being due to a local increase in our postpartum hemorrhage rates. In particular, we were seeing a very high instance of massive obstetric hemorrhage rates. So I'm sure everyone here knows the definitions, but that's looking at postpartum blood loss of 1,500 mils or more. We were seeing sort of yearly averages of around 4%, so higher than we were expecting. And some months we were having as high as a 6% massive obstetric hemorrhage rate, which was becoming quite a concern for us. To try and understand this better, I'd say we sort of looked at this in a rather traditional manner. So for every massive obstetric hemorrhage, I'm sure just like at your trust, a DATEX or incident report would be submitted, and members of the maternity management or QI team would each review that individual case, identify any learning points from that to be shared. Over around an 18-month period, we'd also had 2 audit projects, again sort of taking a portion of random sample of women that had suffered with a massive obstetric hemorrhage to try and understand what had happened, what had contributed to that, and how we'd managed the emergency, and again to identify learning which was shared at our local meetings. But our massive obstetric hemorrhage rates remained high, so we felt we needed to have a new approach, new way of investigating this to understand these trends better and hopefully try and address it. And this led on to this quality improvement project, which is looking at a thematic review of these cases. So we took a 5-month period between December and April 2022 to 2023, and we reviewed all massive obstetric hemorrhage cases that occurred over that period. We designed and completed a pro forma for all these cases, which was really looking at that woman's whole journey through her antenatal period, looking at a summary of that care, any risk factors that she had for PPH, both antenatally and that developed during the interpartum period. We completed a detailed intrapartum timeline, any details of that, and then looked at how the actual emergency of the PPH was handled when it occurred. After the pro forma being completed, we organised an MDT roundtable review so we could work through every single pro forma, discuss them all, and then it would grade the care. And really our aim with doing this was to identify any themes contributing to the cause of the PPH or to the degree of blood loss so that we could hopefully formulate an action plan to try and address this. So our previous approaches is really focused on looking at individual cases. So particularly with the DATEX submissions, it was an individual of the maternity team looking at that individual case rather than taking a wider view. And really we'd looked more at what risk factors the women had and how we'd managed the emergency once it occurred. I think the difference with this thematic review is we could look at the bigger picture. We could follow that woman's journey through her whole care with us. Not just looking at those risk factors and how we managed the emergency, and also by the roundtable looking through every case one after the other. Actually, very quickly you picked up the common themes and threads between them rather than sort of an individual reviewer looking at an individual case. I think sometimes those links get missed, and that made a really big difference. So some of the things that we identified in terms of common themes between cases was the first was around our ability to recognise that individual woman's risk of a PPH. And surprisingly, considering they all had massive obstetric hemorrhage, 94% of the women that we looked at had known risk factors. For us now, trust most common being induction or augmentation of labour and an instrumental birth. But only 19% of women had had a risk assessment completed when they were admitted for labour or for their planned birth. We used an electronic note system, the Badgernet system, and that does come with a pre-built-in PPH risk assessment tool, which we ask all staff to complete for women when they're admitted, either in labour or for their planned birth, be that caesarean or induction. And essentially you tick whatever risk factors they may have, and it does come up with advice on how to manage those women at a higher risk. So things around having IV access or having a postnatal oxytocin infusion. Because we didn't complete the risk assessment, for the majority of women, there were several cases in which that increased risk was not recognised. And so we missed earlier opportunities to make sure we'd got IV access, an up-to-date group and save sample, or to have prepared our intervention, so that postnatal oxytocin infusion. Another common theme was opportunities where we could have perhaps minimised that woman's risk. Obviously, that isn't always possible. But around 80% of our women had an induction or augmentation of their labour. Obviously, for the majority of those women, that's going to be the right course of action, the right recommendation. But this is obviously a known risk factor for postpartum hemorrhage. And really, we should be considering this when making this recommendation. And again, the reviewing team did find some cases where perhaps this could have been avoided. Perhaps women should be made aware of this, that they have fully informed before making their decisions. For about half of the women that we looked at that did labour, there were delays in labour or poor progress. And particularly in the first stage of labour, that wasn't recognised or was recognised late, or perhaps wasn't managed in a timely manner. We also found that for women that were having an induction or augmentation of labour, that often our intrapartum oxytocin wasn't titrated as protocol to achieve adequate contractions. Similarly, around failure to progress in the second stage, missed opportunities where we could have escalated to perhaps the obstetric team sooner to allow for a more timely management plan. And we found that in women that required an emergency caesarean for failure to progress or poor progress in labour, around half of those women had an impacted fetal head, which obviously contributed to maternal injury and blood loss. We felt that if we could improve the management of this labour complication, we could reduce that. And in around a third of women, we found that perineal trauma was the sole cause of the PPH, but was a contributory factor in many others. For lost time, it was unclear whether we'd used our OASI, obstetric anal sphincter injury care bundle, to try and minimise the incidence of perineal trauma or certainly reduce the severity. 38% of all women in this review had an instrumental birth, and the vast majority of those instrumental births were with forceps, which, as I'm sure we're all aware, does have an increased risk of perineal trauma, or particularly more severe perineal trauma, which would increase blood loss. Again, we identified cases where perhaps instrumental birth could have been avoided, or perhaps a ventouse could have been used in preference over forceps to minimise the extent of perineal trauma. And finally, with reducing risk, we also identified some of our management of the third stage, where there were several cases when different clinicians attempted to deliver placenta prior to signs of separation, in some cases leading to things like cord snapping in a retained placenta. And on the other side, when there was a prolonged third stage retained placenta, again, whether we recognised that in a timely manner and escalated that, because sometimes it's amazing how, as we all know, on labour time gets away from us, and we could have perhaps intervened sooner to reduce that woman's blood loss. We also found a real theme around recognising the PPH when it did happen. In 20% of cases, there was a delay in actually diagnosing the issue. And interestingly, all of these occurred when the bleeding was due to perineal trauma. We felt that really this was around individuals becoming task focused when they're suturing and not actually noticing the ongoing or the cumulative blood loss, and only discovering it when you sort of weighed all the swabs at the end of suturing. In 17% of cases, actually, we didn't quite appreciate how severe the blood loss was, because we hadn't looked at that in relation to the percentage of that woman's circulating blood volume lost. For example, we had some very slim petite ladies, low BMI, whereas actually the percentage of blood loss was much more significant than we thought. And perhaps that could have meant we would have considered blood transfusion earlier. We're trying to implement a standard that all blood loss should be measured, but we found that that hadn't really been strictly embedded into practice, and that only occurred in about half of cases. So again, something to work on. When we looked at how we managed the PPH when it occurred, part of our problem with assessing that was some of our limited documentation. Again, we're lucky in that our note system does have a pre-built-in PPH pro forma where you can record all the interventions you've taken or considered, but that was only used in the minority of cases. This meant it was sometimes quite hard to tell exactly how well we've managed that hemorrhage. For example, in only 3% of cases was there any record that we'd performed uterine massage, which I'd hope we'd do pretty much every time. It's almost instinctive, isn't it? But our documentation doesn't reflect that. And that's something that we definitely needed to work on. So that left us with trying to come up with our action plan. So what have we done so far? Because this is a project that's in progress. We've done a lot of work around sharing the learning, sharing these common themes, and how we can try and address these and improve them locally. We've had presentations at local governance meetings, both in our department and at a trust level. We have weekly and monthly maternity newsletters that go out to all staff, so we've included a lot of learning in that. We had a PPH awareness month that was in December. So again, lots of learning going out to staff on a weekly basis by email. We have a closed staff Facebook group, which is really, really helpful. And we had our own local study day, again, to share learning, have a bit of a journal club to discuss current evidence. We even had a teaching model, so the junior staff could practice putting in battery balloons. And I bribed everyone to attend with cake, which does work very well. We've used some of the cases from this review in our local prompt teaching so that we can learn from real scenarios. We've done a lot of updating of our guidance, a lot of staff training on measurement of blood loss, and we've also done some work on auditing our use of the OAC care bundle to again look at whether there's other things that we can do to reduce the severity of perineal trauma. Still to go, we're contemplating a trial of fetal pillow just to see whether we can reduce the impact of those impacted fetal heads. Looking at introducing cell salvage at the trusts, we don't currently have that. We've done a trial but not implemented it. And doing some increased work on training on the OAC care bundles, management of perineal trauma as a focus. And it's nice to be able to close the loop slightly to say actually what impact has that had on our PPH rates, because I'm sure that's what everyone really wants to know. And I keep saying this and touching wood because I don't want to jinx us, but actually we have seen a reduction in our PPH rates. Our MOH rates particularly been within our expected target levels in our dashboard since October 2023. So I'm just crossing everything that stays that way. We have also carried out a re-audit of cases in over a 2-month period earlier this year, again, just to check on how we were doing. I thought there was a lot of positive improvement. So we've seen an increase in that completion of the risk assessment. We have seen quite a reduction in those delays in labour and poor progress in labour, with only 15% of cases in that audit. Our sort of rates of PPH due to perineal trauma staying around the same at about 1/3, but it's helped us identify perhaps some new learning to come out of those cases around sort of prompt examination as soon as possible after birth, so we can diagnose if there's bleeding from trauma and start repair as quickly as possible. But we still need to do some work about that lack of recognition of ongoing blood loss when repairing trauma, as that's still something that we could get a bit better on. One of the things that we weren't so good on last time was activating our MOH call. We have seen an improvement in this, again, still some way to go. And I think it's interesting as Alma measures the side effects of change. Actually, one of the things we've noticed with that MOH call being activated is suddenly we've had a lot of contact from our blood bank going, we're a bit worried, guys, are you sure you're using this appropriately? Because now we're using it so much more often. So part of what we're going to have to go back to them with a bit more reassurance, say, no, actually, it's that we're using it more appropriately now. And also, please expect this number to increase further because that's made a big worry for them. So I thought that was very interesting. Yeah, we have seen that side effect of change. So, like I say, significant improvements, but as always, still some work to do. But I hope that's useful. If anyone wants any further information about the project that we've been doing here, if they think there's something that they can use in their own trust, I'll put my email in the chat as well. I'm more than happy for you to contact me or to take any questions now.
Yeah, I think you've got two things in the chat. One from Grace that was asking about the risk assessments in Badgernet in terms of mandatory field use and whether that's either been used or thought about in your project.
It's not something that we can make mandatory, unfortunately. At the moment, the option is with that form, you can fill it out sort of antenatally at booking, again, sort of about 34, 36 weeks, intrapartum and immediate postnatal. So we said, rather than trying to get everybody fill out each of those waypoints, which I think is rather unrealistic, we really want the strong message to be actually, if you could just do it for the intrapartum one, that would be so helpful, because that's when I think that the changes in risk are the most dynamic. So it'd be nice if we could make it mandatory, but I think we're just working on staff remembering it becoming almost embedded, being built in as part of our routine practice, like a lot of the other forms that we have to fill out, the labour assessments, the partograms, that this almost becomes part of that. I like that themes are identical in your trust. I think that's interesting, and I imagine probably it's part of why I wanted to include them, because I thought I bet a lot of people are going, yep, sounds familiar.
Yeah, and I think it just sort of displays how complex the project is, that your aim was to reduce your overall PPH rates, but actually the problem leading to a PPH was so multifaceted that actually you're looking at lots of different projects with lots of little process outcomes, which then relate to your main aims outcome measures. And Angela, you've got a question for Jen?
I've got two, sorry, Jen.
That's all right.
Apologies if I missed this, but what is your target rate for your PPHs?
So for our MOH rate, our target is 3.7%. I'd say it has been previously 2.5% up until about 6 months, a year ago, but really in response to changing national levels, because looking at the most recent sort of national research audit data, actually is more sort of 3.7%. So that's what we've set our target to, which is sort of more realistic.
Okay, and the other question was, is your blood loss weighed from all modes of delivery? Is that something that is embedded in your culture, or are you still using EBL?
It should be. Since sort of June 2022, we made a change to say we want all blood loss to be measured. And obviously we know from looking at other people's work that it can, that can lead to a jump in your rates. But even so, actually, we found we were having high rates before and high rates after, so we couldn't use that as an explanation for it. In terms of whether it's embedded practice, I still don't think fully. I think there is still a bit of eyeballing going on. We're much better at it in the theatre setting. I think when you've got your theatre staff and your theatre team, they're very good at, as soon as those first set of 5 swabs are used, they're passed out, they're weighed, you're using the suction to collect blood loss, so it is a much more controlled environment. I think for PPH in the room, in the delivery suite rooms, that's where it's a little bit more hit and miss. So that's something we're still working on, like you said, to become really embedded in our practice.
Thank you.
No problem.
And Grace has asked for a copy of your presentation to share with the governance lead. So I'll send out a copy of all the presentations to everybody, so everybody can have access to those.
Thanks, Kirsty.
Has anybody else got any questions for Jen? Or if you want to, you can just put it in the chat and she can answer as you think about it. Yeah, Grace, feel free.
Yeah, I mean, this is kind of going out to everybody in the room, really, but is anybody here using MBL really successfully in their areas? Because I think we're all experiencing the same challenges with PPHs, and the same contemporaneous measurement of blood loss is really challenging. And there's something to be said about the under buttock drapes that are being used during suturing. Some people have had those changed. They're not clear anymore with gauges on them. So if there's any best practice around contemporaneous measurement of blood loss, especially in the rooms, that would be really helpful to share. Thank you.
Yeah, and Grace, if you want to put your email, people can contact you if they want to share any work that they've done, or vice versa. You can contact others. And Eleanor, you've got your hand up.
Yeah, just in answer to your question, Grace, yeah, it's completely normal routine practice in Wales. Now, we just don't estimate. There are certain scenarios in which we do, such as a pool birth. There's lots of research going on around, and nobody's quite got on top of that problem yet. But we just don't talk about estimated blood loss at all anymore. So if you want to link up, I'm happy to share. I'm about to present what we OBS Cymru, but that's not really part of it. It's more about the QI side of it. I haven't really spoken about. It's the question that comes up all the time. We just met recently with the OBS UK lead midwives, and I just said just to preempt, everyone will ask you about how you manage to measure blood loss contemporaneously, but it is doable. And you know, we started this project in 2016 and now 8 years later, it's completely sustained and we all measure blood loss as a routine. So happy to talk to you about that if you'd like.
Because I was going to let you defer to your expertise then, because we're still a few years behind on that journey.
And I think that
Hopefully in 8
probably
years' time.
yeah, it just highlights if, you know, if that's been 8 years, don't stop if you're not seeing it quite yet. Like culture in itself takes 2 years to try and embed it. You've got new people, new staff moving through. So just keep chipping away the little bits of improvement. So I think that introduces us quite nicely to Eleanor, who's going to present about the works in Wales with Obs Cymru. So I'll leave you to Squaresheen and carry on.
Thank you. Hopefully my presentation's just loading up now. There we are. So this leads on really nicely from your previous presentation. And it was really interesting listening to that because I feel like that's exactly where we were before this project, all of the same issues. And when you were talking about people getting really nervous when you start measuring blood loss, that your PPH rates are going up, but they're not. You just know what they are now. But we had all of the same conversations about, you know, putting out more MOH calls and our PPH rates are creeping up and up and up. But of course, we were just estimating before, so we didn't actually really know what our PPH rates were. So yeah, really interesting. So yeah, my name's Eleanor McGillivray. I'm consultant midwife for quality improvement and population health in Cwmtaf Maganog University Health Board. That's what that word says. But you'll see a few Welsh words over the course of this presentation. But for the lifespan of the Obs Cymru project, I was the national lead midwife, so I'm here talking from that perspective really. Although, like I said, it was 2016 that we started this project, so it's been a while and I'm pulling a bit on my memory, but I'll talk a bit around the QI side of things, although there may be some questions that crop up around the practical side of PPH management, but feel free to, you know, pop your hand up during the presentation. So just to put the project into a bit of context, it was a national project, but we're a really small country. So we've only got 7 health boards and 12 obstetric units in Wales. So that's the size of some of your kind of local networks, isn't it? You know, it's very, very small. We've got a population of about 3.2 million and just over 30,000 births a year. So when we talk nationally, we're really lucky that our national is still quite small. So therefore, you know, I suppose easier to achieve things nationally. So the project launched across the whole of Wales in 2016 and ran for 2.5 years up until 2019. And our obstetric units are all very different as well. So we've got some bigger ones. Our biggest obstetric unit has about 6,000 births a year. And our smallest obstetric unit does around about 500 births a year. So very, very small for an obstetric-led unit. So as you can imagine, we had everything in between, and we've got completely different geographies, and we've got one health board with no obstetric unit at all. It's all just midwifery-led community care. It's very, very rural, and the type of place where they drive an hour and a half to get to a home birth. So really, really different across the patch in terms of trying to implement something nationally. So our aim was working together to reduce harm from postpartum hemorrhage. And when I reflect on it now, that is quite a vague aim. There's nothing particularly smart about that aim. It was kind of an idea of somebody that they saw that there was an issue in Wales and thought, right, we need to work together to reduce harm. But how do you begin to sort of quantify what harm looks like? So firstly, we had to be a bit more specific in terms of using the model for improvement. We had to be a bit more specific about exactly what it is that we were trying to accomplish and how do you know that you've reduced harm. So again, this looks a bit like a sketch on the back of a fag packet, and in some ways it was to begin with. So it started out with a brilliant anaesthetist and haematologist in our one of our big teaching hospitals who'd done a research study and noticed some things over the course of the research study that were a bit incidental and were helping to improve the care around postpartum hemorrhage, and then literally scribbled on a piece of paper, we could go national with this, we can scale this across Wales. And so this is where we started out with. These are the kind of broad things that we want to achieve. And obviously it evolved a lot. And again, I look back now and I think we could do a lot better with that. But that's the nature of quality improvement projects, isn't it? They can and should and do evolve. So we had 4 pillars of intervention, and these are the things. So there was research studies, OBS 1 and OBS 2, and I'm sure you'll start hearing more about OBS UK. So this was like the building blocks and the foundations of OBS UK. There were 2 research studies, OBS 1 and OBS 2, and they noticed that there were certain things that were separate from the research study, but that were absolutely improving care for women suffering a postpartum hemorrhage. And those things were a universal risk assessment, so risk assessment for all women on admission to labour ward. And this is the one I suppose you've been talking about in your previous presentation, is measurement of all blood loss contemporaneously from the point of birth. And that was really the thing that everything else hinged on. And then early senior MDT involvement. And of course, you don't really know when you should be getting the MDT involved unless you're measuring blood loss. Because one thing I have learned is you sort of look back on estimating 20 years of estimating blood loss and think, I don't know what we were doing. How can you sort of eyeball something and make clinical decisions on that? But obviously that's what we were doing. So everything hinged on that, measuring blood loss. So early MDT involvement, and then ROTEM guided blood product management. So those are the 4 pillars that across all those obstetric units in Wales, we needed to implement those. So I suppose slightly different from some QI projects that you go into and you're testing what works and what doesn't work. We knew what did, but of course we knew what worked in a big university hospital. We didn't know how that was going to work across all the different obstetric units in Wales. So I'm going to go through the next 2 things together. So how we know that change is an improvement and what changes can we make that will result in improvement. I'll cover both of those. So again, going back to that, how do we quantify it? How do we measure harm? So we had to put some measures around it. So we had that overall aim, not very smart, but some smart measures underneath it. So we wanted to reduce the number of women receiving more than 4 units of red blood cells, reduce the number of women undergoing hysterectomy. But again, on reflection, thankfully, hysterectomy is quite rare. So it's not a particularly good measure unless you use it as a composite nationally to tell you whether your improvement project is working or not. But we did collect it, and we did have some interesting results. Reduce the number of ITU admissions due to PPH, and reduce FFP usage. So those are the kind of things that we decided, that kind of reducing harm in itself we couldn't measure, but those are the things that we could measure that would tell us whether we were moving towards our aim or not. And then there were a couple of things then that we realised were missing from that list for a nice rounded family of measures for a QI project. So we added in a couple of balancing measures. So what was the women's experience of PPH? Because we could get this all absolutely right, couldn't we? And meet all of those lovely sort of outcome measures, but completely traumatise women in the process, because there was a lot more going on around bleeding, and probably a lot earlier as well. So we added in women's experience of PPH, and I suppose one of the unintended consequences that we thought may happen is that we would, their experience would get worse as a result of the other things improving. So that's one of the things that we kept an eye on as a balancing measure. And then of course staff experience, and and on reflection, I wish we'd collected a bit more, really, because there were some really interesting things, particularly from midwives who just felt like, I've got to be an octopus now, I've got to deliver a baby and do this and also measure blood loss at the same time. So those were a couple of balancing measures that we also collected. And of course, the 4 interventions that we put in place, we'd need to measure those too. Otherwise, we'd never know about the uptake of those interventions. So quite a lot of measures, really. When you think sometimes with QI projects, you can keep it to 3 or 4 measures, we had quite a lot. So we had various measurement tools for that. So for our outcome measures, they were collected. Each of our health boards had a local, we were really, really lucky when I think about it, had a local champion team that were funded by the project. So there was a midwife, a haematologist, an obstetrician and an anaesthetist. And generally speaking, it was the midwives that drove the QI across all the health boards. yeah, I'm making a sweeping generalization, but generally that's true of a lot of QI, isn't it? You know, so our champion midwives, there was a bespoke database. Now we are digitally not enabled and quite poor in Wales. We're still slightly in the dark ages. It's all on paper. So that's, I suppose that's where you're a bit luckier. And I was just listening to it and feeling slightly jealous that you were able to record some of that those things routinely on a digital system, but we're not digitally enabled in Wales. So this was time and effort on champion midwives' part to put a lot of information onto a database that we could then use, you know, periodically to assess the project, both locally and nationally. So they used it for their own purposes, and then we used it as a national team as well. And then for our process measures, we had regular audits. So that was an audit of all women, not just those who had a PPH. So for our database, any woman that lost over 1,000 mils, her details were entered onto the database. But for some of these things, like early identification of blood loss, it was no good just asking that question of women that had a PPH. We wanted to know those things about all women and routine care. So we had regular audits as well. And our balancing measures in terms of experience were collected via patient and staff surveys. So again, on reflection, we probably could have lightened our load a bit in terms of data collection, but it's really hard once you start collecting it because it's really interesting. We learned loads, but actually for QI purposes, we could have slimmed it down a lot. And sometimes there were battles between the team about how much we should be collecting as well. We had a lot of conversations about data. And then in terms of PDSAs, then that really was left to the local teams. As I've said, all of our units were completely different. It wasn't up to us as a national team. We could give some support to that. And again, picking up on some of those conversations in the previous presentation, we did loads of sharing and learning. You know, if we could see, as a national team, we were lucky that we could keep our eyes on everything. So if we could see something was really working over here, we absolutely shared it with another unit over there. You know, it wasn't about us. The benefit of everybody working on the same thing at the same time was there was a lot of learning happening really quickly. So we used to bring our champion midwives together regularly to do lots of sharing and learning, but that would look different for each of them. For example, the really small unit, their rotating machine was kept a long way down the hospital corridor in theatres because they couldn't have a rotating machine dedicated to a labour ward that had, you know, 500 births a year. So that's where the local PDSAs came in. And it's surprising what's universal, isn't it? Cake also works for us. Cake always works. So as soon as you said that, I thought nothing changes. It might be over the border, but you can get people to come and engage in quality improvement with cake. And then just in terms of some of our data, we did see exactly what we were hoping to see. So we did see quite a significant reduction in red blood cell usage. And I've got loads and loads of data, and I wouldn't bore you that I could go on about our data. In terms of our measuring blood loss from the point of birth, you can see then we got up to almost 100% in all birth. And actually, if we carried that on in terms of vaginal birth now, the OBS Cymru paperwork is used across all the health boards in their governance and in their risk reviews. So we know that it's part of routine practice. It's a question that's asked, was blood loss measured contemporaneously? And we shared this, we shared data in infographic form regularly. It was helpful for sharing and learning. So if we could see that someone was 100% for blood loss, then obviously we could do a bit of appreciative inquiry, but also there was that little sense of competition as well. And I don't think that hurts either when people are working on the same thing at the same time. And then, you know, use of our ROTEM. So all of our process measures as well as our outcome measures, we collected and we shared those as well as our experience data. So just by way of a summary, we started off with a fairly vague sort of broad aim. So we needed to look at kind of proxy measures, I suppose, for what constitutes harm. We knew what interventions would work. We'd learned that through research. So we knew it would work, and generally speaking with the QI, you go into it testing changes, but actually there's a lot of local QI work and methodology that was used to implement that locally. We definitely collected too much data, and once you start, you can't stop because it's so interesting. There's things we learned about PPH, things that I think, oh, I wish we'd just kept that a bit more robustly because they make lovely write-ups, but we didn't, and there we go. But in terms of QI, just enough is good enough. And we reviewed those aims and measures regularly, and we tweaked them and adjusted them, and it absolutely did not look the same at the end as it did at the beginning, as should be the case in a QI project. That's a really whistle-stop tour of almost 3 years worth of work.
Thank you. That was really insightful and also really interesting when you're just all going, oh, okay, no, we feel the same, or we learnt that. We were just a couple of steps backwards. But you do have some opportunity to ask Eleanor some questions about her project relation to the presentation or not. So feel free to pop your hand up or pop it in the chat. I think you might have answered everybody's question by just doing your presentation.
There's a lot in there, isn't there? And I know that obviously OBS UK is coming, so all of this, you know, you'll get to experience all of this for yourself shortly.
So what would be your take-home message for those that would be embarking or starting on the OBS Bleed study that you guys have learned through the OBS Cymru in terms of their project work that they're going to be doing soon?
I think for me, it was, I know I said it a couple of times during the presentation, but keep the measures as slim as you can, just enough to know that, you know, in terms of your process measures, that the things that you want to be happening are happening. So fidelity to the model, and just enough to tell you if your QI is working or not in terms of, you know, your measures. And just don't be afraid to keep tweaking it. Don't feel like, well, this is what we said we set out to do in the beginning, because actually you learn so much as you go along. You have to be really, really responsive. And then loads of practical questions will come out around measuring blood loss. That was the thing that came out time and time and time again. And really happy to be contacted about that. It was the same 4 or 5 questions every time.
Thank you. Yeah, if you're happy, you could pop your email in the chat and people can contact if they feel that they would like that expertise. So thank you very much for everybody that's attended today. If nobody's got any questions, then I'm happy to give you some time back on your day, which I know is very valuable for everybody. So thank you to Alma for doing the teaching on setting the aim, and followed by Jen for her PPH reduction presentation, and Eleanor on the OBS Cymru work that you've done. So thank you very much for attending. I'm just going to pop a link in the chat, which is where you can utilise if you want to join and share learning or ask for learning for other people that's working on improvement projects. Because this is recorded, I will send everybody who's attended a little newsletter which will have a link to the recording and access to the presentations as well, so you can look back on them. I'll also just put a link in the chat where as we all want to learn, would appreciate your feedback on the event. So what you felt is beneficial and works well, and what you might find useful in the future. And also, because we all love certificates, when you've completed it, it will email you a certificate to the email that you have put in, so that you can evidence some learning for your continuous practitioner development. So I'll leave you guys with 15 minutes back on your day, and hopefully see you at any future events. The next one is going to be focusing on measuring. So because you've attended, I will share information about our future events as well. Thank you very much. Bye.
Thank you.